Welcome. Thank you so much for joining us for our community of practice today. Um, our presenter today is Dr. Michael Gerald. He's going to talk to us about addressing the mental health needs of persons with disabilities. Um, and we're just so happy to have you all with us to spend a little time and learn with us. So I'm going to pass it over to Holly, our team member here at MultiNet, to do a little introducing, and then we will get started.
Thank you. Good afternoon. Oh, Mindy, can you turn on the captions, please?
I've they
Are
are
they
on.
going? Awesome.
So
Thank you.
if you're not seeing them, you should be able to
Thank
show
you.
them on your end.
Good afternoon, everyone. My name is Holly Ennis Poe, and I work at the Institute for Disability Research Policy and Practice at Utah State University. Together with my colleagues, Mindy Dokas and Eduardo Ortiz, we'd like to welcome you all to another community of practice organized by the Multicultural Disability Network and Training, MultiNet's project that seeks better understanding of the challenges faced by people with disabilities, the intersectionality of disability and multiple social, economic, geographic, and cultural factors, among others, create complex contexts that need expanded conversations and learning opportunities such as this community of practice event. As part of MultiNet efforts, we have developed other products I invite you to look at and explore, and that link will be placed in the chat. I am really excited for this month's meeting, addressing the mental health needs of persons with disabilities, which will be presented by Dr. Michael Gerald, who is an assistant professor of rehabilitation counseling at Utah State University. Dr. Gerald is a licensed clinical mental health counselor and a certified rehabilitation counselor. His educational background includes master's in rehabilitation counseling and a PhD in rehabilitation counselor education and supervision. In addition to his teaching duties, Michael also serves as the director of clinical rehabilitation counseling services, which is an on-campus teaching and learning clinic that provides clinical mental health counseling services for persons with chronic illness, disability, and neurodevelopmental disability. So before starting, let's just briefly introduce yourself in the chat with your name, location, organization, and role. And just remember, this webinar is a space for constructive discussion, not debate or argument. So let's keep the conversation focused and avoid side discussions. Keep an open mind and be open to learning something new. Avoid making assumptions. Be respectful of others. Listening is just as important as talking. And ask questions to gain understanding and clarity. You can post those in the chat and we'll manage and pass those along. And a final reminder, this community of practice meeting is also recorded. So please keep your mics muted during the presentation. Dr. Gerald, the stage is yours. Thank you.
Thanks, Holly. First things first, just from a technological standpoint, I do have two screens. So if you see me looking to the left, that's me looking at all of the participants. If you see me looking straight ahead, that's me looking at my PowerPoint and obviously into the camera. I also wanted to take a quick moment, Holly. I can't help myself. I just want to say hi to all of my MRC USU peeps. Brad is here, Anisha's here. Hey, Chris. I saw Rachel. I saw Caitlin. So I just want to say, excited to see some of my former and current students here. Today, we're going to be talking about addressing the mental health needs of persons with disabilities. A couple of things I want to clarify before we get started today. What I'm going to present to you all is a model for practice. And what I mean by that is I'm not going to share specific interventions or techniques. I'm not going to share a particular theory. Instead, the model I'm going to propose today and share with you is one that we've developed through our practice here with Clinical Rehab Counseling Services on USU's campus, and it is a trans theoretical model. It is a model that is grounded in humanism. However, it is a model of practice that can be integrated with any type of approach that people may have, whether they be more pragmatic or social constructivist or psychodynamic in their approaches. We believe it applies, and you'll see that as we go forward. The other thing I wanted to say about the approach that I'll present today is, although it is a social justice oriented approach, It is a disability affirming approach. That also means it's a decolonized approach, meaning I don't necessarily think that the medical model has been overly helpful in promoting social inclusion, social support, and disability identity among persons with disabilities. And as I'll talk about later, all three of those factors promote adjustment to disability. So what we're going to talk about today is not just what the particular mental health needs are for persons with disabilities, but also how practitioners across the spectrum, whether they be peer counselors, I see Wendy here, whether they be peer counselors and peer supports or directors of centers for independent living or mental health practitioners, our model is meant for people to be able to support persons with disabilities in a way that is, again, empowering, disability affirming, identity affirming, etc. Okay. As was already introduced, I am an LCMHC here in Utah. I am the Director of Clinical Rehab Counseling Services here. And if you're curious about my prior work as a clinician, I've been a mental health clinician in corrections, private practice, substance abuse treatment, and I even did a couple of years as a crisis counselor. So a lot of where this model came from is not only informed by my professional practice as a clinician, but I am also a person with a disability. I've had a disability since I was 18 months old. And so when I was tasked with creating a specialty clinic here on USU's campus, I tried to come up with a model that was the most congruent with my rehabilitation counseling background, but still could exist in a clinical mental health counseling setting. And what we came up with is Clinical Rehab Counseling Services, which provides clinical mental health counseling for persons with chronic illness, disability, and neurodevelopmental disability. As Holly already stated, our clinic has been open since January 2021. And since then, we have seen over 590 clients. Holly, this morning I checked, we're at 597. So I was this close to being able to say 600. We've seen over 590 distinct clients, and we've conducted over 12,000 counseling sessions for persons with disabilities. So what I'll discuss today is a model that came about with a combination of research, existing literature, and our own experiences both as persons with and practitioners for persons with disabilities. So I'm going to define clinical rehab counseling, but more importantly, its perspective with respect to serving persons with disabilities. And I'll talk about that going forward, about how it does differ from traditional mental health counseling and other mental health related fields like clinical social work, marriage and family therapy, and psychology. I'll then define response or adjustment to disability and its effect on the counseling process, and I'll identify and describe factors that influence response to disability. So I will share briefly what some of the specific mental health needs are for persons with chronic illness and disability, like feelings of grief, guilt, shame, depression, anger, of course. But more importantly, I'm going to talk about what the experience of adjustment to disability is, particularly that we see among those that we serve. Oh, and I guess I should say too, Holly already knows this, and some of the students here know this. In addition to being a clinician and practitioner and assistant professor here at USU, I do volunteer with a national organization that provides a week-long stay-away camp for youth with chronic illness and disability, and I've been doing that for 20 years now. So a lot of my experience professionally is working with and supporting persons with chronic illness, disability, and neurodevelopmental disabilities. So first things first, what do people with chronic illness and disability want and need from behavioral health providers? From behavioral health providers, persons with chronic illness and disability often report that above all else, they want hope. Now, this gets a little bit tricky when we work with persons with chronic illness and disability, because it may not necessarily be hope for a cure, hope for a full recovery, hope that I can get back to where I was before I acquired a disability, if it's a person with an acquired disability. But more importantly, it's hope that things will be okay. Maybe my life will be different, but it will not be over. Maybe I will be different, but I may not be inferior or undesirable or burdensome, etc. Persons with chronic illness and disability do want ideas. Now, I'm going to talk later about our approach here and my approach as a clinician. I do tend to be more non-directive. my experience as a person with a disability, and certainly something I hear from my clients. And if there's anyone here in the group that has a disability, you know, people with chronic illness and disability are constantly told what to do. We are constantly given ideas of how we could do better, how we could be better. Oh, you know what? You just gotta, if you think about, have you tried, have you thought of, constantly. So when I talk about ideas, what we tend to find is in a non-directive approach, what we do is we serve to validate client experiences and empower them by trusting their judgment. Now, the word judgment is critical here, because judgment doesn't mean correct or accurate. So if I have clients who believe that a certain thing will work, I'm perfectly okay with them trying it, and I will be here next week just as neutral, just as supportive, just as unconditionally regarding, just as non-judgmentally accepting as I was the week before. Persons with chronic illness and disability do want their providers to understand the role of prejudice and discrimination, specifically ableism, and how it impacts their ability to navigate their environment, how it both promotes barriers to access and also diminishes their personhood. A lot of clients that we work with, which is it's a really interesting phenomenon, will report that they can tell a difference among practitioners who don't work with persons with chronic illness and disabilities frequently. And I don't really know what that means, but the research demonstrates that even clinicians, and most certainly master students, will report feeling unprepared to work with persons with chronic illness and disability. And what I want to share with you today is I don't actually think it requires much in the way of specialized training. I actually think that I actually think that there's a lot in our general counselor education and preparation that already helps us to be suited supporters for persons with chronic illness and disability, regardless of our training background or personal experience. And then lastly, persons with chronic illness and disability want a practitioner, a supporter who demonstrates a willingness to walk alongside. For any of you who have experienced chronic illness or disability or work with persons with chronic illness and disability, and I apologize for the excessively clinical language I'm about to use, but sometimes chronic illness and disability just sucks. Sometimes you are just in pain. Sometimes you are just sick. Sometimes there isn't anything you can do to make it better. So is my clinician willing to sit with me and suffer? I have a client right now who will experience such sadness in session that we will quite literally sit there 6, 7, 8 minutes in silence as she cries silently, softly. And then at the end of session, I tell her I will see you next week. And that's because I recognize that right now where things are, there isn't much progress to be made. There isn't much movement to be had, and there isn't anything that she should or needs to be doing in this moment. So I need to demonstrate a willingness to suffer with, to walk alongside. And by the way, walk alongside doesn't only refer to suffering. It can also mean, as I mentioned earlier, trusting my client's judgment, supporting them unconditionally. When it comes to resources for persons with chronic illness and disability, persons with chronic illness and disability often demonstrate autonomy, independence, and control are the most sought after goals. Control is a bit of a dubious concept in chronic illness and disability work insofar as we recognize that we cannot control everything, but persons with chronic illness and disability will want to establish some degree of control in their lives. No, I may not be able to control my symptoms, but I would like the ability to have say in the kind of treatment that I get. Additionally, social supports and support groups can help reduce isolation, provide role models, normalize disability experience, and provide validation while challenging negative views of oneself. And that then tells us that community and social integration, reintegration, are by far the most important outcomes in working with persons with chronic illness and disability. What people with chronic illness and disability need more than anything is social support and social inclusion. It is the difference between being dehumanized in the context of life and experience with a chronic illness and disability and being rehumanized through the counseling or support process. So the emphases that I want you to keep in mind today as I go through our model is when it comes to helping persons with adjustment to disability, the first thing I always recommend to practitioners or supporters is self-awareness. Even some of the most well-meaning practitioners can still hold a degree of ableist ideas such that, well, you shouldn't want to be that way. I remember being 21, seeing a doctor and having him want me to go see a surgeon at the University of California, San Francisco, because he looked at me and said, "You're a young guy, you don't want to live like this." And so what we need to do first and foremost when we support persons with chronic illness and disability is we need to be aware of what are our own views about chronic illness and disability. And by the way, it doesn't always have to be negative. Sometimes our ableism can even be benevolent. If you've ever heard things like, your disability is actually your superpower, the only disability is a bad attitude, those kinds of I know Brad's smiling to himself, but those kinds of inspiration porn type of sentiments actually aren't any more helpful to persons with disabilities than more malicious forms of ableism. Those can be patronizing, paternalistic, minimizing. So what we want to do first and foremost is be self-aware of our own attitudes regarding disability. We also then want to focus on meaning making for persons with disabilities. One of the things that I focus on with the clinicians that I train is I don't actually ask them to be experts in any particular chronic illness or disability. Back in the day, I used to do HIV/AIDS related education. So I knew a lot about human immunodeficiency virus. I knew a lot about acquired immune deficiency syndrome, opportunistic infections, etc. But I don't need to know that as a practitioner, as a supporter, to support someone with HIV/AIDS. I have to tell you, I know enough to be dangerous about muscular dystrophy. I know enough to be dangerous about the different kinds of strokes. But that doesn't mean that I can't employ a process of counseling and support that relies on the subjective meaning making from my client in order to promote healing. You tell me what it's like to be in recovery from a stroke. You tell me what it's like to live with an amputation. We also need to emphasize that there is no correct adjustment to disability. There is no right way to do it. I do presentations for disability support groups, and I find that they often rely on stories of overcomers. And it gives the impression that there is a certain way to adjust to a disability. You got to climb a mountain, you got to run a 5K, you got to start a nonprofit, something to that effect. And what you have to emphasize in your work through non-judgmental acceptance, through a more neutral stance in working with your clients, is that there isn't a right or wrong way to adjust to disability. I also want to, and I really can't stress this enough, I really want to emphasize the role of the therapeutic or healing relationship or connection in supporting persons with chronic illness and disability. When you look at the adjustment to disability literature, there is no singular factor that promotes adjustment to disability like social support and inclusion. So for persons with chronic illness and disability, having somebody who doesn't judge them, who doesn't reject them, who doesn't expect them to do or be something that they are not or may not be able to be, that is in and of itself healing. Having the foundational connection with a caring, accepting other that then makes it so that I have the courage or the wherewithal or the willpower to go try things, to go be who I want to be, that is often plenty. I also think it's important that we demonstrate a deep understanding of those that we work with and not assume. I am often asked if my own disability experience informs how I understand my clients, And that's a very easy answer for me, and that is no, absolutely not. In fact, I find my own personal experience to be a really unreliable indicator of what someone else is going through. No two folks with a chronic illness or disability experience it the same way. Now, we can certainly experience similar things, but our contexts are different. The nature of our diagnoses are different. The severity or collection of our symptoms differs. So when it comes to understanding the experience of persons with chronic illness and disability, I highly recommend that people spend a lot of time listening. You tell me what it means to have this diagnosis, to have this chronic illness, etc. I also want to emphasize acceptance. I recognize in this particular political climate, acceptance has a political connotation, but I actually mean something else. When I say acceptance, what I mean is however a person presents to me, specifically a person with a chronic illness and disability, their presentation in that moment is acceptable. If they believe themselves to be worthless, if they believe that nobody cares, if they believe that they'll never have the life that they wanted or otherwise could have had because of chronic illness and disability, in that moment, that is okay, that is perfectly acceptable. Now, if you're wondering, what about acceptance with respect to identity, such as accepting clients based on sexual, gender identity, racial, ethnic identity? For those who have had class with me before, you know that that is the bare minimum expectation of a counselor, that is the bare minimum expectation of a helper. I'm talking about another level of acceptance where the client can think, feel, or do anything, and that is acceptable. I'm going to talk later about how that helps for persons with chronic illness and disability, but I just want to emphasize when I describe acceptance, it means I do not automatically seek to change those I encounter. Lastly, and this is kind of a fun one, I actually don't necessarily think further expertise on disability and chronic illness is always helpful. Certainly, you know, if you're working with somebody with who is on TPN, which is like a nutrition replacement, yeah, learning about it is interesting. I don't actually think that makes it easier for me to understand what my clients are going through because of this focus on meaning making. So what I would suggest is for those of you who work in settings where you work with a lot of persons with disabilities, rely on your clients to teach you what it's like to live with a disability. Look for themes across persons with disabilities. We have an inclusive post-secondary education program here on campus. I would be looking for themes across persons with intellectual disabilities who are attending college. Let clients teach you what it's like to have a disability. Themes of burdensomeness, not good enoughness, not having the life I want, purposelessness. By the way, it can also lead to pride. It can also lead to greater meaning, greater learning, like self-learning. All of those things are possible. I would allow clients to teach me. So when it comes to disability experience and the meaning making that our clients engage in, that the persons we support, love, and serve, that meaning making comes from their social environment, who they're around, who they have access to, and how those folks react to chronic illness and disability. Their internal, personal factors. This can be things like religious, faith tradition, ideas about disability, even my temperament. Am I generally a more reactive or less reactive person? Our environment can determine the meaning making that we engage in around chronic illness and disability. I've shared this example with students of mine before. A good friend of mine who uses a wheelchair grew up in rural North Dakota. Her school, the lunchroom was downstairs. And so for her entire elementary school experience, she ate lunch with a teacher. Now you might hear that and think, well, that's really sweet of that teacher, but it also means that during really critical peer social relationship years, my friend was having to eat lunch with a teacher because of the environment. The environment can also include access to specialized healthcare. It can also include whether or not you have access to healthcare coverage like insurance. And then lastly, developmental factors. Where does chronic illness and disability occur with respect to development? Some of the children that I work with at the stay away camp where I volunteer will be impacted by chronic illness and disability such that it could actually impede their growth. I work with kids who, because of malnutrition, might be really small in stature. And if you're small in stature and you're identifying yourself in terms of your relationship with and your status among your peers, that can impact the meaning making you engage in around disability. Is disability a good or bad thing? Am I good or bad? Am I worthy, etc.? One of the things that I think is really interesting, and it's something that guides the clinical work that I do, is this idea that a proposed end state of adjustment to disability is this idea of transcendence of disability. So this is a quote from Reed, 1991. There's a universal human desire for transcendence and connectedness. Transcendence is defined as a level of awareness that exceeds ordinary physical boundaries and limitations, yet allows the individual to achieve new perspectives and experiences. Awareness of self-transcendence refers to the developmental maturity whereby there is an expansion of self-boundaries and an orientation toward broadened life perspectives and purpose. So think about it in terms of disability has become so integrated into who and how I am as person that it is simply a part of me. It's not a limiting factor. It's not something that needs to be fixed or cured or mitigated. It is something that is simply a part of who I am, as would be my religious affiliation, as would be my race, ethnicity, my sexual or gender identity, etc. So when it comes to transcendence, there are three particular constructs that we're looking for. When I identify transcendence in clients, by the way, I just mean internally. I don't necessarily tell them, you've transcended, you've made it. What we're looking for is, have they found meaning and purpose in disability? My disability means, if you think about meaning and purpose from a counseling standpoint, meaning refers to the why I'm here. Purpose refers to what am I supposed to be doing. So it could very well be, growing up, my grandparents were deeply religious and they believed that I had a disability and I went through what I went through, years of being a sick kid and in and out of the hospital. They believed that God had a plan for me. That was how they made meaning of disability. For me personally, as I've gotten older, disability gives me a lot of purpose. My primary value is service to others, and that comes from the fact that I have been served. I had many people who helped me along the way as somebody who grew up with a disability. Your clients or persons you support might also reevaluate goals and identities. If I define myself in terms of physical ability and now I suddenly experience a physical limitation or impairment, I might have to rethink how I think about myself. I might have to reevaluate goals. Notice I said reevaluate, not abandon. I worked with a young woman who had experienced a stroke and she wanted to be a teacher. And after her stroke, she was left with chronic fatigue syndrome. So teaching small children for 7 to 8 hours a day became really difficult. We didn't abandon the idea of teaching or working with children. We just identified what would that look like going forward. She ended up taking a job working in a preschool. Shorter days, more people around, you're not the sole teacher, etc. Your client might also discover personal strengths. They might also find positive aspects of disability. For my former students, I feel pretty leery about these two. I would recommend not, oh, hey, Dawn, I didn't even see you here. I would not recommend doing this in a rote or directive manner. Meaning, I wouldn't recommend asking the client, what are some positive things about having a disability? But it seems like you do still have strengths. You're a survivor. I wouldn't recommend that. Your clients will discover personal strengths. They will find positive aspects of disability as you are accepting of them as they are. Your acceptance of them with chronic illness, disability, and neurodevelopmental disability demonstrates that they are acceptable as they are, which then allows them to stop worrying about whether or not disability is objectionable, whether or not disability is inherently bad. Additionally, clients of ours, persons we serve, persons we love, might eventually take pride in mastery of disability. You know, maybe I didn't think I could still go backpacking even though I have a disability. Maybe I didn't think I could still hike anymore after the stroke. Maybe I didn't think I could get back to writing. Maybe I'm a writer. But now that I figure out how to do it, I often will describe to clients, when it comes to disability experience, it's often less a matter of if I can do something and more a matter of how, and I can take pride in doing that. Persons with chronic illness and disability often stop seeking out new experiences, and so novelty is generally a part of a satisfying life. Persons with chronic illness and disability will eventually start trying new things as they become more comfortable and self-accepting. And then lastly, and this is, I think, one of the more beautiful elements of transcendence, assisting other persons with chronic illness and disability can promote adjustment to disability. If any of you are familiar with peer counseling models, such as those adopted by the VA, even those adopted by like AA, Alcoholics Anonymous, and Narcotics Anonymous, this is the exact model. Being a peer support, being a support to others with disabilities is part of my own adjustment to disability. So, the therapeutic process in adjustment counseling, my former students will recognize this right off the bat, involves a foundational relationship that is comprised of three critical elements. It is comprised of a healing connection with another who is genuine and authentic. I don't have to tell my clients that they are in a safe space. I don't have to tell my clients that I care about them. I am demonstrating that because I genuinely and authentically feel that. I genuinely and authentically experience that in the moment. It also is a healing relationship that is built on a foundation of unconditional positive regard. Now, I know, and I'm not going to spend a lot of time on this because I know I'm already running out of time. I know that when I share unconditional, and Holly, you'll remember this, people will go to the most extreme, right? But what about? And then we'll think of the most heinous things that a human being can do to another. Well, what about clients who? What about clients that? And when I describe unconditional positive regard, I mean the genuine, authentic care for another as person. I spent 6 years working for the Department of Correctional Services, and one of the more rewarding parts of my job was being able to demonstrate unconditional regard, unconditional care for those in need, for those that I served, even though they had also hurt others. Unconditional positive regard. And then lastly, as I alluded to earlier, deep empathic understanding. Remember, empathy is not the same as sympathy or pity. If any of you see those tear-jerking Shriners commercials where they parade children with disabilities out to tell you to donate money to them, it is very easy to immediately become teary-eyed. But that initial response is sympathy or pity. Empathy is I can approximate how someone else is feeling because I understand why they feel what they feel, and I can only get that through listening for deep understanding. I can see how that scares you because you told me blank. Empathy has both a cognitive and an affective or emotional component. So what does the therapeutic process look like? Well, a person talks. And by the way, I recognize not everyone here is a therapist, so I would say any relational process looks like this. A person starts by talking. You might, if you're Wendy and you work at Options for Independence, you might ask somebody to tell you about themselves, right? Tell me about yourself. They talk. And then through your interest, your engagement, your active listening, someone will continue to explore. You might say, I've been really struggling lately ever since my diagnosis. And I might say, tell me more about that. As someone continues to explore their internal processes, their internal meaning making. And remember, the reason I left up the other diagram is because all of this is happening in the context of a caring, accepting other. People will begin to learn things about themselves. I didn't know I thought that. I didn't know I felt that. I haven't said that to anyone before. And if we learn things about ourselves in the context of a caring, accepting other, and remember, not just caring and accepting in one instance, but someone who's reliably and dependably, non-judgmentally accepting, unconditionally regarding, then I can begin the process of self-acceptance. Maybe, just maybe, I am okay as I am. So when it comes to key skills for adjustment to disability counseling or supporting others with disability, remember that the ultimate goal of adjustment to disability is an integrated, affirmed sense of self that involves acceptance of disability, which requires an orientation of non-judgmental acceptance and the pursuit of deep empathic understanding on the part of the therapist or supportive other. This last point, that last italicized phrase, is incredibly important. What we want people to feel from us is a singular motivation to understand their perspective. I don't want people to perceive me as trying to fix them, as trying to solve problems. And Jen, who's on the call with me today, can attest to this. We have clients who tell us after going to clinicians who are not disability affirming, they just kept trying to fix it. There is real power in somebody sitting across from another who has no other motivation but to understand how they have experienced something. So how do we do that? We paraphrase. Somebody might say something, and I might say, oh, okay, so things have been really different ever since that diagnosis. We can reflect. Now, I can reflect simple feelings. You've been really scared lately. I can also demonstrate feeling validations. It makes sense that you were scared because this really changed a lot in your life. I can also offer interpretive reflections of feeling. So maybe the client says something like, I've been really angry lately. And I say, you know, you're saying anger, but I'm getting the sense that you've been really fearful lately. And then lastly, we can reflect the meaning behind what people are telling us. You know, I'm getting the sense as you're describing these interactions, there's been a lot of rejection lately. So there's a theme behind what people are telling me. I can also offer interpretations. This is where I synthesize multiple pieces of information and I offer new insight, a new synthesis, a deeper meaning that helps tie together seemingly disparate experiences. You know, I get the sense that in your interaction with that person you met on Tinder, and then that interaction you had with your parents around illness, you've been experiencing a lot of rejection lately, interpretation. By the way, the Tinder example is a real example from a good friend of mine with a chronic illness who is trying to date and has been rejected multiple times on dating apps based solely on chronic illness and disability presence. The next one would be self-disclosure. This is where I can use what are called Rogerian self-disclosures. Now, I do want to be careful. For those of us who work in the field, both as not just clinical counselors or clinical therapists, but also as peer supporters. So for instance, some of the disability support groups I present to are persons who have similar medical conditions to me. I will provide detail-oriented self-disclosures around my medical history. Certainly that can be helpful. But Rogerian self-disclosures are our experiences of another in the moment. Our experiences of another, something to the effect of, you know, I have to tell you, I'm feeling protective of you right now, like almost defensive of you as you're beating yourself up. You know, you sharing that with me is heartbreaking for me to hear because it doesn't align with how I've come to know you. That would be a Rogerian, a self-disclosure of my experience of another in real time. Additionally, when it comes to supporting persons with chronic illness and disability, observation and validation are helpful. So meaning observing people in real time. I don't mean this in a psychoanalytic way, but even something like, I can tell this is really making you nervous, or I get the sense you're not really wanting to talk about this today. I also do want to make a quick note about validation. Remember that validation is not affirmation, it's not agreement, it is not praise. Persons with chronic illness and disability experience often praise that is seemingly undeserved. A friend of mine gets praised for showing up to work, and she's like, I get dressed every morning just like everyone else. When we describe validation, what we are describing is, I understand where you're coming from because. I understand that this is something that's really depressing because I know how much you were looking forward to having children. I understand because. When persons feel validated, this is where you'll see and hear words like, I felt seen. They got it, they understood, they get me, etc. Now, our goal is disability identity. So when it comes to a coherent, affirmed disability identity, your client, person you care about, or person you're supporting will develop a generally positive sense of self. Now remember, you don't want to swing too far in the other direction such that we become arrogant or narcissistic, but I will become generally positive in how I view myself. Maybe, just maybe, I'm not as bad as I think I am. Maybe, just maybe, I'm okay. They will start to demonstrate a greater degree of acceptance, which is I become open to a wide variety of emotional experiences. Maybe, just maybe, sometimes I become anxious, but my anxiety is not something I need to fix or correct. I have a client right now who experiences emotional intensity. And after a time working with her, we've come to a place where emotional intensity is a part about me. It's not necessarily something I have to fix or correct or excise. And then lastly, a greater degree of confidence. And this means I begin to trust in my own judgment and decision making. So when a person has a cohesive, coherent sense of self, they will experience a positive view of self and openness to a wide array of experiences and confidence in their judgment and decision making. What we observe in our work in the CRCS is we generally observe people with chronic illness and disability moving through 4 phases in a fluid manner. Survival is when I am sick, when I am recovering from surgery, when I am undergoing treatment, when I am in a flare. And what I will often describe to clients is at this stage, in this phase, the only thing I need to do is persist. You don't have to raise your hands, but if anyone on the call has ever been so sick or in a flare or coming out of surgery that you feel quote unquote dead to the world, that's survival. I don't need to do anything except persist. The next phase, and this is often the ones clients of mine will overlook, is recovery. Even clients of mine with severe and persistent mental illness. They'll have a manic episode, they'll experience psychosis, and then the day that symptoms start to subside, I'm back at work. I'm back on the trail mountain biking. I'm back running around with my kids at soccer practice. And what we have to tell our clients in a gentle way is we do need time to get back into life. Eventually, we get back to living, doing all of the things that constitute our quote unquote normal life. And then eventually we get to a point of thriving, where not only am I living my life, but my life is meaningful, it is fulfilling, and I'm not only doing the things I need and want to be doing, I'm starting to push the bounds of what I'm capable of. So what I propose, our phenomenological, relationally based, non-judgmentally accepting approach is non-directive in nature. That doesn't mean it can't be directive. We just believe that as part of eschewing the medical model, We believe a non-directive approach is most affirming and most empowering for folks with chronic illness and disability. We believe that persons with CID do already spend much of their time adapting and adjusting to life with a disability, and our role is to help them make sense of that experience and find meaning in that process. We believe that persons with chronic illness and disability are often told what is wrong with them and what they could be doing differently or more effectively. As a result, we believe that in a non-judgmentally accepting manner, we can validate all client experiences with disability, and we do not set goals or expectations for improvement. I will tell you that one of the most significant stressors that persons with chronic illness and disability experience is I can't meet expectations. I can't do what's expected of me. I don't have the energy for it. I'm in too much pain. I can't physically do that anymore. Maybe I don't want to do that anymore. So what we try to do is remove expectation from the process of helping. Conversely, we utilize a humanistic approach that seeks to heal our clients holistically such that there is a higher likelihood that they develop a sense of self that is more self-accepting, thereby reinitiating the self-actualizing potential through the development of a disability identity. So, what are psychosocial considerations in adjusting or adapting to a disability? First things first, remember that for adjustment to disability, it is never a process that is completed. It is never one that is finished. Instead, people adjust to chronic illness and disability throughout the lifespan. And I want to be clear, I don't mean that in a defeatist way. I don't mean that in a way so as to, provide some degree of cynicism or hopelessness about adjustment to disability. But instead, what I describe to folks when I do these kinds of speaking engagements is we just aren't done adjusting or coping with chronic illness and disability because we haven't experienced everything that life has to offer with a chronic illness or disability. I have friends of mine who, as they've aged, have acquired new chronic illnesses or disabilities. And most of you probably know, if you know folks with chronic illnesses like Hashimoto's or POTS, there are probably other diagnoses coming down the pike. So it's important to note that adjustment to chronic illness and disability is lifelong, it's ongoing, it's fluid. It's not something that your client or person you're supporting can say, teach me how to do it, and in 12 weeks they've completed the process. So I want to set the stage. First things first, remember there is no right or wrong way to adjust to a disability. Remember that we want to emphasize acceptance of chronic illness and disability, and we also want to emphasize the meaning making that persons engage in around disability. In my career, I've been practicing as a clinician since 2013. I've never found it helpful to tell people how they're feeling based on what I read in a book. Oh, sorry, I'm pointing at my bookshelf. It doesn't really help for me to say, well, according to Falvo and Holland, persons who experience heart disease often experience blank, blank, blank. It's much more, oh, hey, Becky, it's much more helpful for me to listen to my client and to have them tell me why something feels the way it does, why they think the way that they do, why and how they have come to experience their chronic illness and disability in that way. I do also want to concede that when it comes to adjusting to disability, I'm talking a lot about meaning making and social support and inclusion. I do want to concede that although the medical model has been truly inept and in many respects harmful in terms of social inclusion and equality and support and disability identity for persons with chronic illness and disability, it has, from a practical and behavioral standpoint, dramatically improved the lives of persons with disabilities. I don't say this lightly. My very first surgery happened around 18 months old. I am quite literally dead without the medical model. I don't get to live every day without the medical model and the medical supplies that I use. So there certainly is a practical and behavioral element to adjustment to disability. And I have found that Peer support groups are really helpful for this, where persons with chronic illness and disability can belong to groups where other members with lived experience can say, have you tried, have you thought about, etc. What we're going to focus on today, though, are the social, emotional, and psychological elements of adjustment to disability. When people acquire a chronic illness or disability, and I would argue some of these do actually apply to persons with congenital disabilities, they might experience demonstrate one of 5 coping strategies that come about in the literature. The first is denial. Persons with chronic illness and disability might deny the reality of their situation, the permanence of their disability, the severity of their chronic illness. Denial is often given a bad rap. I used to work in corrections. I used to work in substance abuse treatment. When you tell someone they're in denial in those settings, it's a bad thing, and it's something that they have to remedy right away. In this context, I would argue denial, although not helpful in the long run, is helpful in the short term. For any of you on the call who have acquired a disability, short-term denial can be helpful in getting me back to work, can be helpful in me engaging in activities of daily living, parenting, etc. So denial, yes, it's not helpful long term. It can be adaptive in the short term. Regression, this is where I subconsciously revert to an earlier stage of development. So for those of you who are familiar with psychoanalytic or psychodynamic psychotherapy, you probably have heard of regression as an ego defense mechanism as identified by Freud. That's the regression we're talking about. Now, what does that look like in chronic illness and disability? If any of you have ever worked with persons with chronic illness and disability, or if you yourself have experienced this, I might have been independent. And now all of a sudden I'm more dependent. And I want to be careful, not just in terms of my needs, but in terms of my self-perception. I'm not as capable as I once was. Persons who were emotionally regulated and now are more emotionally dysregulated, those would be signs of regression. Compensation, I joke with Professor Hunsaker all the time. I'm a big time compensator. So we learn to counteract functional incapacitation in one area by becoming stronger or more proficient in another area. There were a lot of things I couldn't do physically as a kid because of how sick I was for so long, but I read every book I could get my hands on. I did everything I could at school with respect to extracurriculars that weren't athletic in nature. I was like, you know what? I can use my brain. And that made me a big time compensator. Rationalization, people might seek out socially acceptable reasons for their behavior or excuse themselves. So if you've ever heard folks say, well, I can't do that because of, and then they cite chronic illness and disability, that would be a rationalization. And then lastly, and this is one that I see a lot amongst friends of mine who are persons with chronic illness and disability, diversion of feelings. This is where I might divert more negative emotions into more positive, or at the very least, more useful emotions to help me get through, to help me get by, to help me thrive, etc. So something that I see among persons with chronic illness and disability, just who I know personally, humor. Taking painful experiences and making light of them, joking about them. If any of you follow sports, you might see persons say, oh, you know, people doubt me and that drives me. That's my inspiration. That would be diversion of feelings. I'm going to share this, and then I'm actually going to stop. There aren't actually that many more slides. I'm going to share this slide, though, and then I'm going to go to my conclusion. Number one, for the sake of time, but also because I do want to leave some room for any questions or thoughts people might have. When it comes to what causes stress and health conditions, what I often share with people is health conditions, with the exception of a few. For instance, a traumatic brain injury can actually change my personality. Heart disease can actually lead to depression. But generally, when people experience distress in response to chronic health conditions, it's because those health conditions pose a threat to them of some kind. So they can threaten my life and my health, think in terms of mortality. They can threaten my bodily integrity and comfort. Comfort, obvious, how I feel physically, but integrity would be my ability to trust my body. If any of you on the call have a chronic illness, you might wonder, like, ooh, what's my body going to do if I go on that trip? What's my body going to do if I take that job? Certainly, chronic health conditions can threaten independence, privacy, and autonomy. Quite literally, for those of us who have chronic health conditions, our doctor's appointments can be pretty invasive. The questions that people ask us in describing our symptoms and experiences can really threaten our privacy. Chronic health conditions can also threaten our self-concept, how we see ourselves. They can threaten our life goals. I shared that earlier, meaning what I wanted to do with my life. They can threaten or compromise or fundamentally change our relationships. They can certainly threaten my economic well-being. And they can also threaten home and place, meaning they can quite literally threaten where I live. Am I near specialized care? Do I live in an accessible environment, etc.? So in conclusion, I'm going to skip these. This time, Jen, I get to do the Cornel West quote. You stole it last time, and that is not fair. I know. I picked it, and then you stole it. Cornel West, in his book, Race Matters, said, although people are somewhat invested in self-preservation, people, especially marginalized persons, are hungry for identity, meaning, and self-worth. So when it comes to supporting persons with chronic illness, disability, and neurodevelopmental disability, what I want you to remember is that research on adjustment response to disability consistently shows that the most consistent protective factor relative to disability adjustment is social support and social inclusion. So what I want you to take from today is that above all else, above technique, above problem solving, above skill building, above advice giving, a healing, humanizing relationship with an empathic, understanding, and authentic other is the most effective means of supporting persons with chronic illness and disability as they move towards establishing a life worth living. Thank you, everyone, for your time today. I apologize for moving so quickly through the slides. We do have a few minutes left. If there are any questions or comments that I can address, we do also have a plan to have the questions taken from the chat. I'll respond to them and then they'll post them on the website. So if we don't get to everything, that's okay. I'll go ahead and stop sharing.
Thank you so much, Dr. Gerald. I'm not closing the meeting right now. I just wanted to quickly say I posted it in the chat, but I just shared a survey with everyone. Please let us know about your experience before you hop off the call. We would love to hear any and all feedback. And yeah, I'll just, if anybody has any questions, you can unmute and share with us, or if you want to put it in the chat, that'd be great too. We do have a few questions from our registration that people put in their registration, so maybe I'll grab a couple of those. But if anybody on the call has a question, please feel free to jump in.
Really quick, Mindy, there is a question. What are the credentials to be able to provide disability adjustment counseling? I assume, Lisa, that was what you meant by DAC. I would say, actually, there aren't a set of credentials. Unlike other practices like EMDR, ART, where you might need to be licensed, I would say if you're a certified rehab counselor, if you're a life coach, anyone who is serving or if you're a peer support person, anyone who is helping and supporting persons with disabilities, I would argue that our model is perfectly usable and perfectly integratable, so to speak, into your work.
One of the questions from the registration that I think would be really interesting to have your input on is, and I'm probably going to say this word so wrong. I don't know how to say it. I had to Google it. Would love for you to touch on anosognosia, something like that for practitioners. Someone who isn't aware that they have a disability or something. That's what I Googled, and that's what it means. Maybe I'll put it in the chat too so you can see it. But the question says, I think a lot of folks experience clients with it and have difficulty navigating those conversations. So I'd love to hear your perspective. Are you familiar with that term, Dr. Gerald?
You know, that's another one, Mindy, that I'm familiar enough to be dangerous. So I won't speak as an expert on that condition, but just to broaden out, I do actually think that part of that question is, okay, how do you provide disability adjustment counseling to folks who don't identify as persons with chronic illness and disability? For all of us here who might be persons with disabilities or know folks with disabilities, you know that not all of our people identify as persons with disabilities. I have friends of mine with my same condition who don't identify as persons with disabilities. So I can't speak to, I'm not even going to try and say it, Mindy. I can't speak to that specifically, but I will just say that something that does make this work a little bit trickier is not everybody is intent on adjusting to disability. Some of our folks are more intent on recovery, getting back to how I was, and integrating disability into identity actually isn't what they would necessarily want to do.
Thank you. Um, there's two other questions. Maybe I'll just put in the chat if you want to take a minute to talk about them. If not, we can, like you mentioned, we'll send if you want to write up a little bit of a response and we can share those later on. Here's
And
one.
Mindy, if you're okay, I think I'll have to write up, oh, oh man. It's a really good question, but I actually have a client waiting downstairs, so I do have to go. Mindy, if you wouldn't mind, I'll answer that. What I'll also do, since Mindy is going to stay on the call, I am going to put my email in the chat, and people are more than welcome to also reach out to me directly. But Mindy, I'll answer those questions and we can post them.
Yeah, and like I said, if anybody else on the call still has some lingering questions, please feel free, even after Dr. Gerald heads off, you can add those to the chat while I'm still on. And we would love to update any responses that he shares with us. But thank you so much for your time, Dr. Gerald. Thanks so much, everyone, for being here. I will post a link, one more link into the chat as well to our website. We have another one of these.
Thank you, Dr. Sorry.
Yep, next month. So if you are interested in joining us, I'll put the link to that as well. We actually have next month's presenter on with us. Brad is gonna present for us next month, and we're so excited to hear from you as well.
I'll do my best to make it fun.
It'll be great. Let's see. Let me find her. Okay, so I just put it in the chat. There's a link to our website. So if you haven't already been to our website and seen it, you can go visit it. And we also have Brad's community of practice registration on our website. So please join us next time if you would like to. And thanks again for joining us today. It was a great discussion, and I'll stay on for just a few more minutes if anybody has any other questions.